I would like to thank the organizer for giving us an opportunity to present our abstract. So we would like to report our experience using Cladribine in Erdheim Chester disease, and I'm speaking on behalf of our group at the Mayo Clinic. So Cladribine, it's been about 50 years since this drug was synthesized, and it's about 25 years since it was approved for hairy cell leukemia. And as most of you know, it is a molecule very similar to deoxyadenosine, except that there is a chlorine substitution at the 2 position of the purine ring. It is considered as an anti-metabolite. So Cladribine is resistant to ADA or adenosine deaminase, and therefore it is not metabolized and excreted through the uric acid pathway. So it is preferentially then phosphorylated into chlorodeoxy ATP. And this deoxy ATP is actually toxic to lymphocytes, and it kills dividing cells by DNA strand breaks and also causing apoptosis. We know about the effect or efficacy of Cladribine in hairy cell leukemia, but also it has effect on a lot of other B-cell disorders, including chronic lymphocytic leukemia, Waldenström macroglobulinemia, and other low-grade lymphomas. Also, it is effective in acute myelogenous leukemia. There's been a couple of reports in adult histiocytic disorders. I think the biggest series, I believe, it was first published in 1999 by the group from the Scripps Clinic. And this was using Langerhans cell histiocytosis. The dose that they used was 0.14 milligrams per kilogram per day, 5-day infusion, and it's given every month up to 6 cycles. And in their report, the response rate was as high as 75%, with a fairly good duration of response at a median of 33 months. So based on this, there has been several reports of using Cladribine in the literature in Erdheim Chester disease. We reviewed the literature just a couple of weeks ago, and we found about 17 cases. The activity in ECD is quite variable. 2 out of the 17 reports did not actually mention response rates or responses. If we looked at the 15 cases, 10 out of the 15 cases, or approximately 60% of the total reported responded, and in 5 patients there was no response. So at least it's showing some activity, at least in some patients. At the Mayo Clinic, historically, Erdheim Chester disease and histiocytic disorders, they were treated by our lymphoma doctors. So they were very, they have used Cladribine a lot in hairy cell leukemia and other lymphoid disorders. And so since 1998 or 1999, Cladribine was being used quite often, especially for patients who were intolerant of interferon. So the objective of this presentation is to retrospectively show our report on the efficacy of Cladribine at our institution. So this is a single institution study. All the patients we're reporting today are adult patients who were seen at the Mayo Clinic. All the biopsies were reviewed at Mayo Clinic, and the diagnosis was made based on histopathologic criteria that was published as a consensus, and also based on clinical findings. So the patient diagnosis dates span from 1998 to 2016, so you can see this is a long period, over a long period of time. There were 2 dosing of Cladribine that were used. The first one was based on the publication in 1999 at 0.14 milligram per kilogram per day, days 1 to 5, and it's given every 28 days. Most patients would have probably have received between 2 to 4 cycles. The other publication was based on our phase 2 trial in lymphoma, which was 5 milligram per meter squared, 5 days every month for 4 to 6 cycles. because Mayo Clinic in Rochester is primarily a referral practice, many of our patients, we collaborate with the community physicians from various states, and so many of the patients were treated locally in the community, and they would come to us for evaluation after a couple months of therapy. So unfortunately, we did not have any uniform post-therapy assessment, so because this is a retrospective study. So for the purpose of this presentation, we defined response by according to clinical response criteria and also radiologic response criteria. For the clinical response criteria, we define CR, or complete remission, if the symptoms went away for at least 3 months, partial response, incomplete resolution of symptoms for at least 3 months, stable disease, no change, and progressive disease. And we acknowledge that this is definitely subjective. For the radiological response, many of the patients, because they were seen prior to year 2010, many of them did not actually have PET CT scan. And so we define CR as complete resolution of the suspected or biopsy-proven lesions, partial response, incomplete resolution, and so forth. So there is limitation with our response criteria. Among the patients that we saw from 1998 to 2016, there were 63 patients who were seen at the Mayo Clinic, and the median age was 54 years, ranging from 18 to 80. 23 patients were BRAF tested, and 52% were positive. Out of the 63 patients, 21 patients were treated with Cladribine, either as first-line or later-line therapy, so about a third of the patient. The male-to-female ratio was 2:1. And you can see that at the time of Cladribine therapy, the median age was about a decade later compared to the time of their diagnosis. So these were patients who were diagnosed and had symptoms, or maybe no symptoms for some time, and then got treated later on. So the median age at the time of treatment was 62 years, and patients up to age 78 were treated. So about 9 patients received the treatment as a first-line therapy, and 12 patients received Cladribine as a later-line therapy. The median number of Cladribine treatment was 2.5 cycles, and you can see 40% of the patients were treated prior to 2006, and the rest were treated between 2007 to 2016. So for the clinical responses, there were 6% of the patients who were evaluable had complete resolution of their symptoms, 46% had some resolution of their symptoms, and the rest either had stable symptoms or progression. None of the patients that we saw and had imaging studies had a complete response. About half of them had a partial response, and about 26% or a fourth of them had stable disease. I'm going to show you 2 cases which were really recent cases or recent patients who we treated, and these 2 patients had PET CT imaging. So the first one is a 45-year-old gentleman who presented with right testicular pain, later had a testicular excision. It was found to have a mass, and then the right testicle was excised and found to have Erdheim Chester disease. And later on, he presented with back pain with a lesion, or actually with a tumor at T3, T4, and also in the aortic arch area. The patient was BRAF V600E negative, did not have the mutation. He underwent Cladribine therapy after 4 cycles. Well, after 2 cycles, he didn't have improvement clinically and also radiographically. After 4 cycles, there was a near complete remission. On close review of the imaging, There are still areas of FVG avidity, so it's not considered a complete response. However, clinically, his symptoms have resolved. The second case is a 40-year-old gentleman who presented with with blurriness and also periorbital swelling, later found to have Erdheim-Chester disease. Had sinus, tracheal, aortic, and splenic involvement, and we can see the tracheal involvement, aortic, and also he has some splenic involvement. And after 3 cycles, most of those areas resolved except for the spleen. However, we do see some bony enhancement after 3 cycles, but he wasn't symptomatic. So this was kind of a mixed response. So 4 patients had grade 3 toxicities. None of them had grade 4 toxicities. 1 had pneumonia, 1 had a central line infection. The other 2 patients were CBC abnormalities, just neutropenia without infection. The other one had neutropenia but no thrombocytopenia. And this is to show you the study limitations, retrospective, many years, and also not uniform response criteria. Finally, our conclusion is that Cladribine has moderate clinical activity in Erdheim-Chester disease. Most patients tolerate the treatment well. For older patients, they're not able generally to tolerate more than 4 cycles of treatment. We usually don't go beyond 6 cycles of therapy, and some patients did have durable responses. Thank you.
Are there any questions? Yes.
Ron, my experience with Cladribine, which could be formed in the BRAF.
My experience with this is basically what you said. Obviously, you have a bigger data set. But for the BRAF negative patients, going to 6 cycles is, in general, very problematic. I wouldn't advise going to 6. I think 3 to 4 cycles should be. Otherwise, you run into eternal, lasting thrombocytopenias and neutropenias that take more than a year to resolve. So I think it's nice you have that median of 2.5.
Yeah, exactly. For younger patients, especially if they have continuing improvement in clinical or radiographic response, we may go up to 6, but you're right. It's mostly about 3 to 4 cycles.
I'm sorry, I think we're very late, so we move to the next speaker.
Thank you.
Thanks very much.